So this is the challenges, right? The cost, I think, is something that we've heard a lot about, so I don't need to spend a lot of time on. And you heard what those are, sort of upfront costs for hardware, software, training, transitions, but just in general, sort of the maintenance that needs to occur as far as HIT. I think we have some unique challenges in the behavioral health world. The treatment workforce differs for the most part from that in medical settings. Staff range from those people who are in recovery without professional training, which most people probably know is incredibly important in terms of mental health and addiction services, having people in recovery sort of involved in individuals' care, but to people with advanced degrees in medicine and psychology. Treatment settings vary a great deal. You've got inpatient detox that may be, if you're lucky, 3, 7, 10 days, drug-free outpatient care that's intensive, residential care, therapeutic communities. Now with the coming online of medications to treat not only alcoholism but opiate dependence, that's sort of another office-based setting where there are implications. So I think that's something else to think about. Treatment often includes a broad range of care, including sort of self-help, 12-step groups, and so I think that's something else that isn't thought about, and that they're often less sophisticated systems. I think one study that was done found that, again, a lot of our providers are still completely paper-based. They collect information on paper, they're entered into unlinked databases, and there's limited or no integration across multiple sources of data. So I'm running out of time. Again, I just want to point out, this is sort of that same study that hasn't been published yet, but was done out of Kaiser in Northwest, in Oregon, I think. But again, sort of they realized the value of implementing sort of HITs. Specifically, this looked at sort of addiction treatment settings, and realized that there are a number of sort of labor-intensive services that HITs could be used to enhance the business case for. And so just want to point out some of that through integrated systems, they found a number of things, that staff time was reduced, the easier access to, client data, reduced clinician time, all those sorts of things that we know have been realized in sort of the primary healthcare system have been realized in the addiction treatment system as well. So just want to wrap up by, I have a few recommendations. Obviously I have 2 pages, but wanted to pull out some of the more, I thought, relevant ones to this conversation. Inclusion and incentives, I have a question mark. For the most part, as I told you, we were not. We're still fighting very hard to see if that's something that can happen, but it's a huge issue. I think around sort of looking at who are the people that are coming to our doors, making sure that behavioral health providers aren't held to sort of standards that don't make sense, colorectal cancer screenings or some of those things, x-rays. Those are things that our people, they know whether they're going to have the capability of doing that. But there are, certain things that need to be done in the terms of specific health implications. And so needing to think through what makes sense and again, what doesn't. Additional funding, I think I already talked about that, the safety net providers in that definition, making sure you're thinking about our people. The safety net people. I think the mental health and addiction providers are often left out. It's just sort of a given that they're included in that safety net, and it doesn't happen. I think by the time the funding gets down, it just doesn't reach us. And I think finally on the sort of issue of meaningful use, I think we feel obviously very strongly about the need for it to be inclusive and thoughtful of treatment planning for serious mental illness and addiction disorders. I've had some conversations with Mike and know there's been discussions within sort of the behavioral health work group around sort of the current meaningful use matrix, and in looking in that, I think it definitely fails to recognize initially at least all the levels of care, which I sort of talked about a little bit, that are really specific to individuals with mental illness and addiction disorders. And while there's probably some level of comparison in sort of the primary health care field, which is something we're dealing with in the terms of parity implementation, but again, looking at there's residential treatment, there's in-home or in-school services, there's intensive case management, which is incredibly important for this population, the therapeutic residential centers for both kids and people with addiction disorders, peer-provided services, the issue of mobile services and homelessness shelters and domestic violence shelters, outpatient, and again long-term residential care for people with serious mental illness, because there are incredible number of people that still need that sort of intensive type of care. And so, for the most part, these programs have standards of practice that are not accommodated by the assumptions in the current meaningful use matrix. And I think, again, that's something that we're really focused on sort of as we move forward. How are we thoughtful about how behavioral health really fits into this picture? And with that.
Okay, thank you, Alexa. Now, also what we'd like to do is try to leverage the use of technology, and I'd like to introduce Dr. Stephen Davis, and he is one of the co-chairs of the CCHIT Behavioral Health Work Group, and I want to have them incorporate some of their comments in terms of reviewing meaningful use criteria and some of the gaps. So if we can... Okay, Dr. Davis, then you're on.
Good morning. Can you hear me okay?
Yes, you're fine.
Oh, great, thank you. Thanks, Mike. Good morning, everyone. I'm the chairman of the Department of Psychiatry at Baltimore Washington Medical Center, which is part of the University of Maryland. And along with Sharon Hicks, we are the co-chairs for the Behavioral Health Work Group for CCHIT. So we've been meeting over this past month and a half or so, and one of the things that strikes us as far as meaningful use is the fact that there's really nothing in there that addresses addiction problems, that addresses mental health problems. And as you heard earlier, 25% of hospital admissions are related to some sort of mental health or substance abuse problem. That's a lot of money. Also, as Alexa also pointed out, that people who are treated in public mental health system with chronic illnesses, chronic severe mental illnesses, on the average die 25 years shorter than the average population. A lot of that is because of problems with coordination of care, limited access to primary care, and smoking, which takes an inordinate toll on people with chronic mental illness. So the Behavioral Health Work Group, there's 11 of us, and we wrote some comments which we submitted, but I thought it's very brief, and I thought I'd read this to you here. Now, these are not comments that are from CCHIT. They have not reviewed these, so it's not a formal statement from them, but it is from the Behavioral Health Work Group. So, as part of the response to the meaningful use standards, we on the Behavioral Health Group wanted to register our concern about the proposed definition for meaningful use, which excludes many of the services that make up the cornerstone of public behavioral health care delivery in the United States. While most of these services are not covered, many of them are not covered by Medicare, they are covered by Medicaid and a number of federal and state and local programs that are patched together. We're very concerned that, in general, these traditional and evidence-based behavioral health care services are really not getting the attention they deserve with the current governmental policies related to health care reform. It's important to note that the patients and consumers in all of these settings are also treated in primary care settings and hospitals. If the behavioral health care providers are left out of the national health care reform plans, and particularly if this care is not coordinated in the context of EHRs and coordination of care, then any new health care system that we develop is not going to meet the goals of being able to improve quality care and decrease cost. Additionally, behavioral health plays an important role in supporting primary care goals for some of the most common and expensive conditions confronting our healthcare system, including more effective management of problems with sleep, anxiety, chronic pain problems, including diabetes, cardiovascular disease, and other disorders related to obesity, smoking, and other consequences of unhealthy lifestyle choices. Behavioral health support for primary care efforts would be very helpful in addressing these problems, which are major drivers of the escalating healthcare costs. And in fact, to ignore these mental health and substance abuse programs within the definition of meaningful use would not be in line with one of the, I think it's 7 core principles of the recently released SAMHSA white paper, and that core principle was to eradicate fragmentation by requiring coordination and integration of care for physical, mental, and substance abuse conditions. So that's all I had to say. Thank you for the opportunity to increase your awareness of this gap that we have.
Great. Thank you very much, Steve. We appreciate you taking the time to join us. Now I'd like to turn it over to Ruth Perot, who's the co-founder and executive director for Summit Health Institute for Research and Education.
Good morning, everyone. I'd like to begin by expressing my sincere thanks to the National eHealth Collaborative Board of Directors for the opportunity to speak with you and for your sustained attention after listening to 5 speakers. And Michael, thank you for asking me to be a part of this very distinguished panel. It's been my pleasure to have participated with NeHC in several ways from the very beginning. I had a chance to testify before AHIC work groups. I was on the group that provided outreach strategies for AHIC successor organization, and I'm currently a member of the membership and communications group affiliated with in the organization now, so I feel like I know you fairly well. I also applaud your efforts to help bring about an HIT network that ultimately will improve the safety, the quality, efficiency, and accessibility of health care in our nation. I bring you greetings not only from Shire, Summit Health Institute for Research and Education, but also from the National Health IT Collaborative for the Underserved. We are a kindred organization, also committed to collaborative partnership approaches, as our tagline suggests. And we too share a commitment to the utilization of health information technology to improve health and healthcare in our nation. But we are also totally committed to the premise that with respect to HIT, no community should be left behind. Backing up. We call ourselves NHIT, and we are guided by a vision of an interconnected public and private health system where all consumers have access to high-quality, affordable care. They will also have access to the information and technology resources that are needed to maximize their access and effective use. Now, this vision lifts up 2 very important concepts for us, and that is the primacy of the consumer. Indeed, the beneficiary of HIT, in our view, must be the consumer. And we also imply, and we will talk about later, that HIT is a tool to be used to assure high-quality, affordable care. It is not an end in itself. Our purpose, then, is to convene community, public, and private partners who will leverage HIT advances to expand access and quality, as both of our organizations agree. NIHIT also seeks to close the health gaps between communities of color and other vulnerable groups in relation to the total population. Again, HIT becomes a tool to achieve a broader purpose. Now, we come to this statement of purpose from a shared concern. Back in 2006, when I became involved in this issue, it was pretty clear that the HIT train was pulling away from the station without a fairly sizable number of people on it. And it became rather evident that if the rest of the nation was about to benefit from health information technology advances and a whole group of people were not, then the gaps that we already see could only be exacerbated. And so this was the key motivation that brought our organization to the point of really committing to this effort to leave no community behind, as reflected in a couple of our goals. We seek to ensure HIT needs of the underserved are met through policies, programs, and research. And we also seek to reach, inform, and educate consumers and providers who serve them to encourage HIT adoption using culturally and linguistically appropriate strategies. By way of background, 6 organizations officially launched NHIT in June of 2008. And they are APTIS, Association of Clinicians for the Underserved, eHealth Initiative Foundation, the Institute for eHealth Policy affiliated with the HIMSS Foundation, the Office of Minority Health, HHS, and our organization, Summit Health Institute, a true public-private community partnership. The 6 currently comprise our management committee, and the organization I represent, Shire, manages the work of NHIT and coordinates the efforts of over 100 volunteers who participate in 4 work groups. These work groups address components we believe to be essential if HIT is to achieve its desired results. And these areas are education and outreach, policy, workforce development, and finance and sustainability.